want you to picture a scenario.
Mm.
It's every ER doctor's nightmare, but at the same time, it's the kind of puzzle that neurologists, they live for.
Mm-hmm.
We have a patient. He's 22 years old, by all accounts, just in the absolute prime of his life. Healthy, active, no real medical history.
Right.
And then he's rushed through the ER doors because he's just had a massive generalized tonic-clonic seizure.
And right there, just stop. Before we even look at a single lab result, the alarm bells are deafening.
Yeah.
A seizure in a 70-year-old, you think, okay, maybe a stroke, maybe a tumor. In a toddler, maybe a febrile seizure. But a first-time seizure in a healthy 22-year-old, that is a biological red flag that something catastrophic is happening inside the brain.
And when we say generalized tonic-clonic, just so everyone's on the same page, this isn't like a minor event.
No, absolutely not. This is what people used to call a grand mal seizure. It's the whole storm. Loss of consciousness, violent muscle contractions.
The stiffening and the jerking.
Exactly. The tonic phase, the clonic phase. It means the brain's electrical activity has just gone haywire across the entire cortex. It is a full-blown medical emergency.
So the team stabilizes him, but now the detective work really begins. Because healthy brains don't just, short circuit like that for no reason.
Right. There has to be a trigger. And this is where the history becomes the most important tool you have.
And it turns out this seizure didn't just come out of nowhere. For the last 48 hours, this young man has been, he's been deteriorating.
The timeline is so critical here. 2 days. That's an acute presentation. It's not a slow burn over months, and it's not a thunderclap headache that happens in a second. It's a rapid decline.
And the symptoms.
He's got a fever, about 101.5 Fahrenheit, and a really severe headache.
Okay, so fever and a headache. Like first thought is a bad flu. Or maybe meningitis. That's the classic triad, right?
Yeah.
Fever, headache, stiff neck.
It is, and meningitis is definitely on the list of suspects, inflammation of the lining around the brain. But there is one detail in the history that just shoves meningitis down the list and puts something much scarier at the top.
What's that?
The family says, along with the headache, he's been confused. And not just, tired from a fever confused, we're talking nonsensical speech.
Okay, so that's a huge distinction. That's the difference between the wrapping paper of the brain being inflamed versus the brain itself.
Precisely. If you have meningitis, you feel awful, your head is pounding, but you usually know who you are. The hardware is okay. But when you get confusion, personality changes, that nonsensical speech, what we call dysphagia, that tells you the inflammation has breached the perimeter. It's in the parenchyma. The gray matter itself is under attack, and that is encephalitis.
Encephalitis, which literally just means inflammation of the brain.
It does. And the seizure confirms it. The inflammation is irritating the cortex itself, causing that electrical storm. So now our mission is clear. We have to figure out what is attacking his brain tissue, and we have to do it fast.
So we have the clinical picture. Fever, acute confusion, seizure. The team orders an MRI right away. And the image they get back is not subtle.
No. The report says bilateral temporal lobe swelling. And that finding is the visual smoking gun.
Why so specific?
In neurology, location is everything. Different pathogens, different viruses, they have the preferred zip codes in the brain. And when you see swelling specifically targeting both temporal lobes, you can almost make the diagnosis right there.
That's incredible. I would have thought an infection would just be messy, all over the place.
This is more like sniper fire. The temporal lobes, they sit right behind your temples. They handle memory, emotion, language processing.
Which explains the symptoms perfectly. The nonsensical speech, the confusion. You're attacking the language and memory center.
Exactly. And the pathogen that has this unique affinity for that piece of real estate is herpes simplex virus type 1, HSV1.
Wait, hold on. HSV1, as in the cold sore virus. The thing that gives you a blister on your lip?
The very same one. Most of us carry it. It's usually dormant, just sitting in the nerve ganglia in the face, not causing trouble. But in very rare cases, and we don't fully understand why, it reactivates and travels the wrong way.
The wrong way.
Instead of traveling out to the lip, it travels inward, up the nerve.
That is a terrifying thought. How does it even get into the brain from, say, the nose?
There's a direct highway, the olfactory nerve, the one for smell. It's basically a part of your central nervous system that's in direct contact with the outside world. The virus can just crawl right along that nerve fiber.
And the olfactory nerve leads directly to the
base of the frontal and temporal lobes. It's an anatomical direct flight. And once it gets there, it's not just causing a little swelling. HSV1 encephalitis causes something we call necrotizing hemorrhagic encephalitis.
Okay, those are three very heavy words. Necrotizing is tissue death.
It's killing the neurons. Hemorrhagic means bleeding.
Bleeding.
Yes. The virus is so destructive, it actually erodes the small blood vessels in the brain. So you have a swollen, dying, and bleeding temporal lobe. And that detail is crucial for the next clue.
Which comes from the lumbar puncture, the spinal tap. They need a sample of the cerebrospinal fluid, the CSF.
The liquid biopsy. The fluid bathes the brain, so any debris from the war happening inside will end up there. We look at three main things: glucose, protein, and cells.
Okay, let's walk through them. First up, glucose, sugar levels. In our patient, the glucose is normal.
Which might sound boring, right? Normal sounds good, but in this context, a normal glucose level is a massive clue.
Because it tells you what the invader isn't.
Exactly. If this were bacteria, like in bacterial meningitis, those organisms would be hungry. They metabolize glucose. They would be eating all the sugar, driving the levels way down. Same for TB or fungus.
But viruses don't eat.
Viruses don't have their own metabolism. They just hijack our cells. So in a viral infection, the glucose is usually untouched. Normal glucose tells you to think virus.
Okay, clue 1 fits. Clue 2, protein. The report says the protein is elevated.
And that's a standard sign of inflammation. Think of the blood-brain barrier as a very fine sieve. Normally, big protein molecules can't get through from the blood, but with encephalitis,
The sieve gets leaky.
the barrier's integrity is compromised. Proteins seep through. It confirms the brain's security system has been breached.
So normal glucose points to a virus. High protein points to inflammation. Now, for the most important part, the cells.
This is the headline. First, we see an increase in white blood cells, specifically lymphocytes.
Which makes sense. Lymphocytes are the body's virus-fighting special ops. If it were bacteria, we'd see neutrophils.
Correct, so that reinforces our viral theory. But there's something else in the fluid, something that absolutely should not be there.
Red blood cells.
Red blood cells, erythrocytes. CSF should be crystal clear. Finding red blood cells floating around is highly abnormal.
And this connects directly back to that phrase you used, necrotizing hemorrhagic encephalitis.
You got it. You're connecting the dots. The virus makes the temporal lobe bleed. That blood leaks out of the brain tissue and into the CSF. So when we do the tap, we find the evidence.
It's the physiological echo of the damage.
It is the neurology rule of thumb, the exam pearl. Red blood cells in the CSF without a history of trauma means HSV encephalitis until proven otherwise. It's the signature.
So the case seems closed. But let's play devil's advocate. Why isn't this just a traumatic tap? Maybe the needle just hit a blood vessel on the way in?
Great question. That's the first thing you have to rule out. But if it were just a clumsy needle, you'd see red blood cells and protein, sure. But you wouldn't see the immune response.
You wouldn't see the lymphocytes.
You wouldn't see the high white blood cell count. Our patient has both. The immune system is at the party. It tells you the blood is part of the disease, not the procedure.
Okay, that's ruled out. What about bacterial meningitis? We have to be sure.
Absolutely. But the clues don't fit. Glucose is normal, not low. The cell type is wrong. Lymphocytes, not neutrophils. And the MRI shows temporal lobe swelling, not enhancement of the meninges, the lining. It's a different pattern of attack.
And something slower, like TB or a fungal infection.
Timeline. Those are chronic. They simmer for weeks, even months. Our patient crashed in 48 hours. That speed screams virus. And again, they eat glucose, so the sugar would be low.
One last one from the differential. Guillain-Barré syndrome, GBS.
GBS is a fascinating comparison. It highlights the central versus the peripheral nervous system. HSV attacks the brain central. GBS attacks the peripheral nerves in your arms and legs.
So the symptoms are totally different.
Completely. A GBS patient isn't confused or seizing. They're perfectly alert, but they're weak. They have an ascending paralysis that starts in their feet. Their brain is fine. Their body just isn't getting the signals.
And the spinal fluid is different too, right?
Very different. It has a famous profile. Sky-high protein, but no extra cells. We call it albuminocytologic dissociation. Our patient has a ton of white blood cells, so GBS is off the table.
It's amazing how by knocking everything else out, HSV1 is the only thing left standing.
And it's so important to get there quickly, because for this, we have a specific antidote. The antiviral drug acyclovir.
And you need to start it immediately.
Immediately. You can't wait for the DNA test to come back a day later. Acyclovir stops the virus from replicating, but it can't undo the damage, the necrosis. That's already happened.
So you treat based on this classic picture.
You see fever, confusion, temporal lobe swelling, and that CSF profile lymphocytes and red blood cells, and you start the acyclovir. That decision can save the patient's memory, their personality, and their life.
It really is a complete narrative arc. The virus gets in through the nose, it targets the temporal lobes, it makes them bleed, and that bleeding shows up as red cells in the spinal fluid.
That's the beauty of it. When you understand the mechanism, that necrotizing hemorrhagic process, you don't have to memorize the list of symptoms. You can predict them. Of course there's blood in the CSF. Of course there's confusion. It all flows from the nature of the beast.
I think that is a perfect place to leave our deep dive for today. It's a powerful reminder that even when the body seems chaotic, it's often following a very specific set of rules. And if you know how to read them, you can solve the mystery.
And in this case, solving that mystery means that 22-year-old gets to go back to his life.
The best result of all. Thanks for joining us for this one. We'll see you on the next Deep Dive.
Stay curious.